dar paso al doctor Pavel Strnad. Él es un experto en déficit de alfa-1 antitripsina en la enfermedad hepática y es el líder del registro europeo en déficit de alfa-1 antitripsina y nos va a hablar de nuevas evidencias y nuevos tratamientos. Thank you, Pavel, for coming.
Thanks a lot for the invitation. You put together an amazing congress, and we can be only looking up to Spain and Germany. We never get 1,000 patients, 1,000 people who care for the liver together. I would also like to thank Juan and Monica, who actually helped us build our alpha-1 antitrypsin registry, and that's one of the reasons I'm here as well. So, as mentioned, alpha-1 antitrypsin deficiency is basically my favorite disease, and that's why you need to suffer through the next 10 to 15 minutes. So, alpha-1 antitrypsin is a major serum protein that is produced by the liver. It's like albumin, a little bit less abundant. It's a major part of the alpha-1 globulin fraction, and it's produced even more in stress situation to basically make sure that we can also calm down and we don't destroy our tissues. So it's a protease inhibitor, and that means that if you have an infection and fight against the infection, at some point there is time to actually go down, and that's what alpha-1 antitrypsin does. Alpha-1 antitrypsin deficiency is an inherited disease where you have a mutation in the alpha-1 antitrypsin gene, and this secreted protein accumulates in the liver and makes in the liver some kind of gain of function toxicity, and the fact that we cannot inhibit the proteolysis leads to digestion of other organs, particularly of the lung, which leads to a loss of function, lung phenotype with emphysema and COPD. So there are many genotypes and more than 100 mutations that have been discovered, but the really most important ones are the PIZZ, which is the homozygous mutation in the alpha-1 antitrypsin gene. MZ is the heterozygous one, and SZ, which is actually quite common in the southern Europe, because the S variant is quite common, is a combination of one severe and one less severe mutation. And the more severe the mutation, the lower the alpha-1 antitrypsin serum level, and the higher the risk for both lung and the liver. But also the lower the level, the less frequent the genotype. So what you have, all of you probably seen or at least met, but maybe did not see, is the heterozygous MZ genotype. In Germany, this makes up about 3 to 4% of the general population. It might be a little bit less in Spain, and is really enriched in any severe liver disease. It's like PNPLA3, a little bit less common, but a little bit more severe on an individual basis. And there is now quite a lot of data showing that PIMZ variant, if you have anything else, increases your risk to develop an end-stage liver disease and to die from liver disease. So it has been shown in classic metabolic diseases, but also in cholestatic liver diseases like cystic fibrosis. MZ patients have also a little bit more of gallstone, so it seems to affect both the biliary tree and the hepatocellular part of the liver. But the really kind of classic alpha-1 antitrypsin deficiency is the ZZ genotype. It's found in about 1 to 3,000 and increases the risk of liver cirrhosis by about a factor of 20, and similarly or even more strongly increases the risk of HCC. We don't really know whether this HCC can develop even in non-cirrhotic liver, but from what I've seen so far, we believe that most of these HCCs develop in F3, F4 fibrosis, so we don't have to kind of do ultrasound on every ZZ patient every 6 months if they have no signs of liver disease. At least that's our current understanding, but the amount of data we have is very low. So what we try to do is basically to put together a large consortium and to really try to understand the natural disease history and to how to manage the patients in the routine. And this This is one of the recent examples where we put together about 700 ZZ patients that get a basic exam with all the classic non-invasive tools like liver stiffness measurement, aeeh, FIB-4, so the usual scores. And they were followed up on average for 3 to 4 years. And we checked all the major outcomes, both lung and the liver. In this cohort, the liver-related outcomes were even more numerous than lung-related outcomes, which is a little bit unusual and shows that this depends a little bit who looks. If this is a cohort collected by lung physicians, you will obviously have much more lung events. And if you have a cohort where the liver specialists are looking kind of more deeper, we will get a liver cohort. And basically, this analysis shows that the standard tools that we use in the routine, FibroScan, aeeh, and so on, are quite good triage tools. So that the usual things, suggestions of cirrhosis and so on, or even advanced fibrosis, is associated with strongly increased risk of developing a major liver-related outcome, which is decompensated liver cirrhosis, hepatic encephalopathy, HCC. The classic events were counted here. And we also, because this is really a disease of lung and the liver, we try to actually compare the lung and liver risks in the patients to kind of give good recommendations. Unfortunately for the lung, it's a little bit more difficult to have good predictive tools, but it looks like FEV1 is kind of the best one, at least from the ones which are commonly used, so that you can use a combination of FEV1 and liver stiffness or aeeh score to get an idea whether you have a patient with a leading lung or liver-associated disease. And based on all these things, there is a new Delphi consensus paper that is just coming up, which basically summarizes how we can handle the patients. This is relatively similar to what you have seen in MASLD and any other chronic liver diseases. And you can basically use FibroScan as a triage tool. And if you have a patient with an advanced liver fibrosis, you will start to look for hepatocellular carcinoma. If they start to have a decompensation, you will consider liver transplant. That actually has a relatively good outcome in selected alpha-1 patients, and vice versa. If you have subjects with low FibroScan suggesting no or minimal fibrosis, a follow-up every 2 to 3 years with a specialist should be sufficient. So what is maybe most interesting about alpha-1 antitrypsin deficiency is that this becomes really a tool of a modern medicine, and a lot of especially nucleic acid drugs are being tested in alpha-1 antitrypsin deficiency. So the most advanced one is fazirsiran, which is an siRNA. So siRNA is a class of drugs which the first siRNA treatment was approved about 5 years ago. These are all drugs which can be extremely well targeted to the liver, and because of that, actually all siRNA treatments that are currently approved are liver-targeted drugs. So there is a special glycosylation that can help to enter into the hepatocytes through the acetylglycoprotein receptor, and in this particular situation, obviously inhibit the production of the mutated alpha-1 antitrypsin. And here are the first data showing that it works. So the easiest way to look at this in alpha-1 antitrypsin is to measure the serum levels of alpha-1 antitrypsin and the hepatic accumulation of the protein. And as you can see, the siRNA can reduce both by about 85 to 90%. And this seems to be also associated with improvement of liver injury markers like ALT, gamma GT. This particular trial went up to a year, so obviously the data on fibrosis are not particularly convincing and need longer and larger trials. There is actually, so there will be one more slide. There is another phase 2 trial that just came out where fazirsiran was compared to placebo, and this trial shows that it is really well tolerated. so that now the phase 3 study is recruiting, and to my knowledge has several Spanish centers as well. So if somebody runs over such a patient, probably Monica or John or maybe other people can help him. Another equally exciting thing is a technique called RNA editing. It's a similar technique, so you use a special nucleic acid which you kind of get into the hepatocyte, and this nucleic acid targets a specific deamidase, which means it makes a change in one base pair, and it can actually lead to a reversal of point mutations. And this actually, the first disease that seems to have succeeded is alpha-1 antitrypsin deficiency. We so far have only a press release which shows that after a single dose of this RNA editing drug, you can flip about 50% or 60% of the mutated alpha-1 antitrypsin into the wild-type protein, which is obviously very exciting and may have implications to other point mutations like PNPLA3. So obviously, alpha-1 antitrypsin is happy to lead the way here, and stay tuned for more. Thank you for your attention.